Okay, this is where we left off on the last one. We were talking about the pelvic bone or hip bone. I should use the same term that they're using here. And there are a couple of other things that tend to be noteworthy. The larger noteworthy type projections or areas. Ischial tuberosity. Uh, it's a projection off the union of the ischium and the pubis, and you can see it here. You see the ischium in the kind of the the ochre color, and then the pubis kind of pinkish, and it forms this projection off the hip bone, and it's the portion that you sit on. So it is your ischial tuberosity. You can feel it through your gluteus maximus muscles, and it's the portion that you're going to sit on when you sit down. And then there's a large, actually the place where the two pubic bones come together is the pubic symphysis, and I think we have another image of it that's a little bit better to look at coming forward. It is a joint. It's considered a slightly movable joint, padded with fibrocartilage. So it is one of your slightly movable joints. In terms of the obturator foramen, the obturator foramen is formed by the ischial and pubic bones for a attachment for muscles, and it is an opening in an opening in a bone, one of your processes. I don't see a pointing to the obturator foramen on this image, so let's move forward and see if we can find an image where we have a better view of it. Yeah, you can kind of see on this particular one, on the left, the bottom labeling, the obturator foramen, it's actually a really pretty big hole that you have. You do have nerves coming through there also. So you do have soft tissue coming through, I guess I should say, as well as just anywhere where you have something that is projecting off the bone. You're thinking what attaches to that. You're just thinking that. You don't have to memorize what attaches to that for the most part. Coaxial bones do make a joint with the sacrum. The superior image that you have here is a nice repeat of the colors of the three bones that fuse to form the coaxial bones, and that you have this joint with the sacrum called the sacroiliac joint, and you're seeing this image here. You're also seeing the pubic joint, where the two pubic bones come together, the two pink pubic bones come together, and then you have that bluish fibrocartilage between. And these are both the bottom one's anterior, the top one isn't quite an accurate image. It's a little bit distorted to show you everything that you want to see. Yeah, I think I've pretty much covered the material on this one. Certainly there is an incredible amount of ligaments stabilizing this joint, and those ligaments are very strong, don't tend to be problematic unless somebody has scoliosis, somebody has a severe gait issue, or if they tend to be a problem as we age. There is this concept of a true and false pelvis. It sometimes does get asked. It isn't a huge topic, at least in most of the basic anatomy classes that I've been involved in. But what you have is you have this arcuate line, And so the true pelvis is the cavity. You have the pelvic rim, which is the upper ridge of the pelvis, and that is the, I guess you might think of it as the negative space, the inside space, the pelvic inlet. It does define the perineum. The perineum region is the inferior portion of the true pelvis, forms the outlet with regard to that, and muscle support of organs of the pelvic cavity is what you find. Mostly what you think of this true pelvis as is this is the birth canal. You think of the true pelvis as the birth canal. False pelvis is the flaring blades of the ilium, and that's the above the arcuate line. True and false pelvis. You also, the side view I think is kind of even more interesting, because in the side view you can see the true pelvis being a an angle from the sacrum, and the false pelvis being everything that's above that sacral joint. And then another interesting concept about the pelvis, the male and female pelvis are different. Well, actually the male and female skeletal systems are different. Your book talks about the skull and the differences in the skull. And certainly if you look at the skull, the male skull tends to have a, well, just generally the male skeletal system is more dense. There's more bone put down. The bone is stronger. Bones tend to be slightly larger. Any of the processes are more exaggerated on males than females. But one place where you see some pretty dramatic differences between the two is in this pelvic area, because women give birth, and most of the adaptations with regard to women and their pelvis, depending on how you look at it, is for the process of giving birth. This is a nice compare and contrast here for the pelvis, and some of it can be extrapolated to the entire skeletal system. Certainly the bone weight, the bone markings. Specifically, the pelvis of the male is more narrow, and the female has a broader whole appearance, and the angle is not as the angle of the arc, so of those ilium, is more shallow. So you have I'm trying to see how they tend to say it. They don't really say that. Shallower, oh yeah, they do. The iliac fossa is more shallow on the female. Sacrum tends to be broader, shorter, and the pelvic inlet, so that's that portion of the true pelvis, is enlarged in the female, and that's why I said that's the birth canal. And the coccyx actually points down in the female and anterior in the male. There's a slightly different orientation of the acetabulum. The obturator foramen is a different shape between the male and the female, and that's so in the male more oval, female anterior, and that's because of this pubic angle. The pubic angle in the female can be more than 100 degrees, and male is under 90 degrees. And so when you open up that pubic angle, that actually shifts the shape of that obturator foramen. So again, all of this is to facilitate not only the birth, but also the carrying the baby, particularly in the 8th and 9th month, the weight of the baby plus the amniotic fluid and everything else. I didn't mean to mumble that. Lower leg bones and then the feet are the last things we need to talk about. We'll probably go into the next portion of this too. This is the femur. Very, very recognizable bone. Generally, even when I start out, and I'm sorry for all this stuff on here, but I wanted to get as much on these slides as possible. But when I first start teaching the skeletal systems, I can usually hold the femur up, and most people will say that's the femur. It's a very recognizable bone, and it's the longest, strongest bone in the body. And again, if I ever hear, if I talk to people and they say, I broke my femur in 3 places or something like that, it was a very serious accident. Usually it's a motorcycle accident or somebody had a pretty vicious fall, because this is a very strong bone, and it generally isn't going to be the first bone to break. If somebody had a broken femur, they had probably had a lot of other bones that were broken. The lower limbs generally are for weight bearing. And with regard to the femur, you have proximal and distal ends, of course. Proximal end is where you have your trochanters, your greater and lesser, and big surprise, they're for muscle attachments. The shaft is one of the longest that you have, the shaft of the femur. In the proximal end, again, you have this head, and this head is what's going to articulate with the in the acetabulum with the coaxial bone to form the hip joint. It does articulate at a slight angle, just like this drawing is quite accurate, that angle of those hip bones. And you have processes for the gluteal muscles, also for the big strong leg muscles, the quadricep muscles, and the hamstring muscles. You do have a prominent ridge on the shaft called the linea aspera, again for muscle attachments. The distal end, you have the knee joint. So the femur's portion of the knee joint, which we'll talk about in further slides. But again, you have these epicondyles. So you have these projections off. They kind of look like knuckles, these knuckle-like projections off the distal end, which we call condyles. And then upon those condyles, you have the epicondyles, lateral and medial. You are going to have a fossa in the posterior aspect, so the intercondylar fossa, and you are going to have a groove or a indentation where the patella is going to sit on the anterior aspect. Here is the patella. Speaking of that, the patella is your sesamoid bone, otherwise known as the kneecap. And there is quite a few attachments for ligaments in the patella. And remember, the patella is a sesamoid bone, so you're actually going to find that in the tendon of the quadriceps. You actually have it attaching in a, you have a ridge where it attaches the patella. And then, boy, I'm sure I probably get to the knee joint. Hopefully I didn't exclude the knee joint for you, because that's another big one. Certainly we have a lot of problems with the shoulder joint, but we have a whole lot of problems with the knee joint in terms of healthcare and people that you'll see. The tibia and fibula are the lower leg bones. We'll talk about them now because they're here. And the tibia we consider that the weight-bearing portion, and it looks like we're going to pick this up on the next one. See you in the next part.